Hello and welcome to the CareMap updates for the updates happening to the Shared Health Guidelines as of tomorrow, October 10th, 2023. So a lot of the CareMap updates are going to be just revisions and alterations to the already existing care maps, but we're going to go over some of the differences because there are some new care maps to review as well, along with reviewing the new vectors guidelines. So the first one is this revised care maps. We have A01, Emergency Medical Services Overview. This one's just been reworded, retitled, and it's just put more in alignment with the college's regulation and practice directions. So this one hasn't really got any drastic information changes. It's more so just more the wording that's involved in the care map. So for A02, A03, C12, E06, there's been no updates to these. They have actually all been deleted. So these no longer exist. They have either been absorbed or reworded into new care maps, or some of them have just been removed from other care maps and made as their own standalone care maps. And we'll be discussing the new care maps in a second. The one big change that we're going to see as of October 10th is in regards to medical service work scope. So as of October 10th, EMR level paramedics will no longer be able to use iGels. The reason for that is the use of EMRs being able to use iGels was for during the pandemic when we couldn't ventilate unless we had a secured airway. That's no longer as big a concern as it used to be, so that has elapsed. So basically at this point, the medical directors have decided we're over the hump of dealing with severe COVID, and we can ventilate patients without an iGel in place. So that has been removed from EMR scope of work. So for A08, orders and delegations, there's just been some, this new care map has been created to replace the old A02. So this one's broken down into different sections here. So we have section A, it refers to requesting changes from a medication standing order. So for medication standing orders, we have the M documents that basically allow paramedics to give medications that they, based on their assessments of the patients and benefits of the patients, they can just go ahead and give these medications, dosing, times, repeats, things like that. It's standing order. So we're not be calling a doctor every time we want to give anything like Tylenol. It's just there. If you want to go outside of that standing order in the M documents, whether it's you need to give a bigger dose, you need to make more repeats, things like that, you're required to contact online medical, or it's going to be vectors. But basically, we're going to be looking for online medical support. It doesn't mean you can't give it as long as it is still within your scope of work. So for example, if you want to give a patient more fentanyl because fentanyl is working really well for you, but you've maxed out your dose and repeats, but you still have an hour left in your transport, you can call online medical and ask to give more. Again, you're not going outside your scope of work, which is very important. You're just making a change to a standing order. The big thing is once you give them the reasons why you're doing it, make sure you have a report ready, why you want to do it, what the difference is, what you're expecting the outcome to be. It is very specific to that patient. You cannot take it to the next patient. So if you have a patient in IFT for 2 hours, you're giving extra pain control, online medical has permitted that. If you have another transfer after that, same situation, you still have to call in. It's very specific to that patient if you want to deviate from the standing orders. Make sure on your PCR, if you do this, you document what the orders given from the physician was, who you talked to, and the time that you contacted online medical. So for section B, ERS and ERS affiliated physicians, this basically talks about who you can take direction from. So again, that's not advice, that's not it's basically who we can take orders from to deviate from the norm when it comes to the M documents. So obviously those ones we can get permission from the ERS medical director, so usually that's online medical. STARS or life flight transport physician, we can take direction from STEMI stroke physician. So like for example, when we can't give an oxyparin unless we get direction from the STEMI physician. And even then, we shouldn't be going outside our max dosing, but they're the ones that are going to decide how much we give because we don't have standing orders. We have our M document that is a standing order per se, but it has to be authorized by the STEMI physician and also the LVAD cardiologist. The big thing is if you're calling for medications and direction, you have to identify what level of paramedic you are, what your scope of work is, because you can't just say as a PCP, say, hey, Maxron's not working, Gravel's not working, can I give this patient a Danzatron? And then have the online medical go, yeah, for sure, when you haven't identified that you're a PCP and that's an ICP med. You can't just do stuff because you said, well, the doctor told me I could. You have to self-identify your scope, and that's very, very important. You can ask for changes in dosing regimens, stuff like that, but you should not be asking online medical to go outside your scope of work. And again, as a paramedic, that's on you to self-identify. It's not up to the physician to figure that out for you. When it comes to IFTs for section C here, it talks about how we can get orders from the sending facility to kind of make some differences. So for example, if your patient needs a lot of pain control and they have standing orders as per for the patient's sending physician, they say, well, they need like 10 milligrams of morphine every 30 minutes. You have that standing order from the sending facility. If you're not comfortable with that, you're always welcome to call on a medical to get further direction. But because it's a sending physician, it's the prescribing physician for that patient, they know them better. So you can follow those. But again, make sure you get in writing in your documents before you leave the facility. Also with that, if you do have any issues with your patient during an IFT, ideally you should be calling the sending facility and talk to their physician, because they'll have a better knowledge and understanding what's going on with their patient versus calling online medical and trying to just sort it out based on whatever you're telling them. If you need to get a verbal order from the sending facility, so for example, yeah, like I need to do something else for pain control, what do you normally do in the hospital? Ideally, documentation is preferred, but if you do take a verbal order from a sending facility, just make sure, again, same thing, document the doctor you talked to, what the orders were, what time, length of conversation. Make sure you document all that thoroughly, especially if you're using like midazolam well outside of what the normal ranges are. So if there isn't, so section D for orders and delegations, talk about an on-scene physician. So if you're on a call, like say an MDC, and all of a sudden someone pulls over and they're like, I'm an ER physician, I'm here to help, things like that. It's great if they want to help. We'll totally accept help. You know, extra hands don't hurt, but we are not under any obligation to do whatever they tell us to. They can't say, I'm a doctor, you will do this. Like if we have a doctor show up and we have so much shortness of breath and they're telling us to needle decompress, we're like, we can't do that. I don't think this patient really needs it. We have every right to say no. Okay, they can't, and we can't just do stuff outside of our complete scope of work and say, well, a doctor told me I could. The big thing to keep in mind is as well, we have to make sure they're actually a doctor. So we can't just go ahead and do stuff because some dude said he's a doctor. So if some guy has been watching a lot of Grey's Anatomy, shows up and says, I'm a cardiothoracic surgeon and do this, do that, do this, you'd be like, okay, I don't know who you are. Like, I've got no idea who you are. So I'm not going to follow your directions, especially if it goes outside of our scope. If they seem like, if they are legit and they seem like they know what they're doing and they're asking us to do stuff that is outside of our protocols, we can, again, say no, but it doesn't mean we just blow them off. We can also have a conversation with the doctor saying, well, you want me to do this? I can't do that, but we do have access to this. What do you think? So you can collaborate and get ideas together. That's totally acceptable, but just don't be doing stuff well outside your scope of work. The other thing as well, you have to make sure that what they're asking you to do is reasonable. They're qualified, and if they do still decide that, okay, this is going to be beneficial, they explain it to you, it makes sense, they are a doctor, we have to make sure if they do anything that's above your scope of work that the doctor is aware that they have to come with you after that. We can't delegate down to lower levels of care. So if you have an ER physician doing surgical airway, you can't say, there you go, guys, and hand them off to a PCP crew to do a 1-hour transport to the trauma center. So we have to make sure that the doctor's aware of that beforehand, because as much as they want to help, they may not want to spend the rest of the day at HSC with us. Again, document everything, document the doctor's name that assisted you, what they did. Again, if it's more so you just had a conversation, but still document that there was a doctor on scene and that they helped out. If the doctor does do a procedure that is within your scope of work, so for example, you're having trouble getting IV, so they do your IV for you. Yeah, that's totally within your scope of work. So just document that the physician on scene assisted, started the IV for you. And that you can take over care for that because they didn't do a procedure that's above your scope of care. And again, document everything thoroughly, especially when we have outside sources helping us. So for Section E, delegations, so as per A01, in a situation where a medication standing order is insufficient to meet the clinical needs of the patient, a physician may authorize paramedic to vary from the standing order on a one-time basis way of delegation. So with that, there's people we can't take delegations from. So an EMR cannot accept any delegation beyond the usual scope of work, even with a physician's order. So as an EMR, if there's an IV, like tube maintenance is within your scope, and they're like, okay, well, you know what, you've got an IV, you need to give gravel every hour through this IV. As an EMR, you can't do that. You can't go beyond your usual scope of work. As a PCP or ICP, you cannot accept delegations from your supervisors. It has to be from online medical or a STEMI physician, or that list I went over earlier. It can't be like an administrative supervisor. The LVAD nurse coordinator, so there's the LVAD cardiologist and there's the LVAD nurse coordinator. There's a difference there. So we need to know who we're talking to if we're dealing with an LVAD, because we can't take direction from the nurse. It has to be a physician. Also, a non-prescribing provider, such as a nurse, CT technician, or technician in a referring facility. So if you're taking your patient for a CT and they're very disruptive, and the CT tech's like, you know what, just give them double the dose of midazolam to calm them down, they can't give us orders like that. We'd have to call online medical to get assistance with that. Another big one as well is paramedic can accept a medication order or delegation to vary a medication standing order from another paramedic. So if you're a PCP and your ICP partner is like, no, you know what would really work is just give a double dose of fentanyl to this patient. That'll be fine. They have no authorization to do that. So we can't just give each other delegations to go outside our regular scope of work. That's orders and delegations. The next update, and this has been a big one, it's kind of hit of a speed bump here, but we have vectors. So A07 is a new care map in regards to how vectors is supposed to work. So ideally with vectors, it's supposed to be that we have one phone call to rule them all. So with that, we have phone numbers for STEMI, we have phone numbers for stroke, we have phone numbers for trauma bypass. The idea of vectors is that it's one resource for paramedics. We only call one phone number. So we would call vectors, we would get answered by ACP or physician and just say, yeah, I need this talk to STEMI physician. So they would put you on consult. And the nice thing about this program, the idea was that, again, we only call one person, but we can also have multiple physicians on the line. So if we have the trauma surgeon or the trauma bypass physician and STARS transport physician and trauma physician all on the same line, we can all have a conversation together about what's going on. So we can all figure it out instead of paramedics calling one person, then calling for a helicopter, and then calling back saying we can't get a helicopter. It just makes it a lot easier for us. And that was ideally the whole plan with vectors. The big thing is when it comes to this, especially with all the bypasses, they want you to call no matter where you are in the province. And that's a big one because there's a lot of things going behind the scenes right now that we're not aware of, especially with transport. So even if you're up north, and you're like, well, I work in the PA, I'm going to go to the PA. Why should I call vectors? But the thing is that now we have the transport physicians on board and they're working behind the scenes. Like before you even get to the hospital, they might already have something in the air flying towards your location. And that extra 30, 40 minutes of flight time that you save by calling ahead of time can make a huge difference to getting the patient down to tertiary care. And even further south, like in the Interlake, like if someone's up in Ashern and you call before if we're going en route to Ashern Hospital, it'll be in 30 minutes. If they can already get the helicopter in the air, you can maybe just bypass the facility and go straight to meet the STARS team at the airport. So just something to keep in mind. No matter where you are, they want you to call for bypass just to confirm. Problem is this vectors initiation has been delayed. It was supposed to go live October 10th. It's currently on hold until a further date that has yet to be determined at this time. So as per that, we are going to stick with our regular activations. So these are the care maps that have been updated. So in the October 10th care map updates, all of these were updated to basically they took out online medical and they just replaced it with call vectors. For all these care maps, so your trauma bypass, your direct transport to palliative care unit, basic advanced resuscitation, LVAD, acute stroke, and STEMI will be in there as well, is that we are still to call online medical. Okay, so with basic advanced resuscitation, especially basic for PCPs, you need to call online medical. It's not vectors yet. You probably get put through to vectors, but we're going to request online medical. For advanced resuscitation, you can call online medical for direction. Pediatric arrest, you should call for pediatric arrests at all levels, just before you just continue resuscitation. But yeah, so we're going to stick with what we're doing before. So with trauma bypass, we're going to call dispatch and say we need trauma bypass. If you're going to stroke to HSE, we're going to still call the HSE paging number. If it's STEMI, we're going to call MTCC asking for the cardiologist. And if it's an LVAD, we're going to contact dispatch or the LVAD coordinator. So those are going to stay the way they are for now. And again, the updates in October 10th were for all these care maps were just more so to put vectors in as a primary point of contact versus actually like recreating the entire care map. So another one we're doing is aerosolized generating medical procedures. So the only one big difference with this, I'm not going to go through the whole care map because it's only one change, is we have the new addition to aerosolized procedure that is permitted with extended PPE only. So with this now, we have updated it where we can give salbutamol by nebulizer for patients under 5, so 5 and under. So that's just the new update here. So ideally, anytime we're nebulizing, so that goes for nebulized epi, all that good stuff, we should be wearing extended PPE. So, glasses, masks, all that good stuff there. So that's just the new addition to that one. It's just an addition, so we can do that. With basic resuscitation, it's, again, the information has not really drastically changed for basic resuscitation. It's more so it's been streamlined. So we used to have separate pages for the actual cardiac arrest versus what we do get ROSC. It's all been put into one flow chart here, so it's just one page to look at. The other big thing of note for basic resuscitation, so when it talks about airway management, EMR is no longer allowed to use an iGel. So when it talks about securing the airway with an iGel, that is no longer within the EMR scope of work. You can still use an OPA, NPA, absolutely, but not an iGel. For advanced resuscitation, it's basically the same thing. There's not really any new information in here. Again, if the new ones say call vectors, that just means call online medical. And it's just a revised flow chart. So the actual information contained in the care map has not changed. So for asthma COPD, this is a new care map. We used to have a respiratory distress care map. It kind of lumped everything into one. That wasn't working for a lot of paramedics. It was a lot of information on one page. So it's been broken up now. So now we have specifically asthma and COPD, which is E07. This will be a new care map coming out. So indications for this care map are patients with dyspnea, respiratory stress, respiratory failure, or known or suspected respiratory failure due to asthma or COPD. There's really no contraindications to this. Obviously, if your patient's not having shortness of breath, we're not going to activate this care map. So big things here. So ensure patient airway and assist ventilations as required. So one thing we have to remember with patients with asthma COPD when we're ventilating is their inspiration versus expiration rates are going to be different. Usually with patients with asthma or their severe COPD, exacerbated COPD, is that their expiration is going to be longer than their inspiration. So it'll be easy to get breaths in. It's going to take twice as long for breaths to get out. So we have to make sure when we're assisting ventilations, when we squeeze the bag, we allow that time for air to escape. Otherwise, we're going to have a lot of gas trapping, or some people call it breath stacking. But basically what's going to happen is we're going to get a buildup of air in the chest, which isn't really going to be beneficial for our patients. So make sure when you're ventilating, like 1 second in, 2 seconds out, to allow that extra time for air to get out, so we're not going to hyperinflate their chest. So just something to keep in mind that when we're supporting ventilations. We can look at giving salbutamol to these patients. Obviously, if we acetate wheezing, salbutamol is kind of our go-to. We'll talk more about that with other conditions later. But with asthma, that's kind of your go-to. And of course, we're not going to deny them oxygen if they're having trouble breathing. So with salbutamol here, so for asthma, COPD, bronchospasm, if all ages available to comply, use an MDI and give 2 to 8 inhalations depending on severity. So again, if you have a 4-year-old that can use an MDI, it has been shown in studies that MDI with a aero chamber works dramatically much more effectively than using a nebulizer. Because when you have a nebulizer, yes, it's easier, but you get oxygen with it, but it's going to miss out. They're not going to get full doses. Whereas when you use a puffer with a spacer device, it's going to be a lot more concentrated. So it is going to be more effective for your patient. But for nebulizers, just because with pediatrics, like obviously a 1-year-old is not going to be able to comply with an MDI. They don't understand like breathe out, breathe in, things like that. They can't follow commands. They can't comply with that. So if they're 5, and again, with kids with airway respiratory stuff, the big rule is don't stress out the kid anymore. They're already in rough shape. And hypoxia is the biggest cause of out-of-hospital sudden cardiac arrest. So we don't want to be irritating these kids and making things worse. So if they're not able to use MDIs, if they're 5 or under, we can nebulize now, which is awesome because like it sucks when you try to use an MDI on like a 2-year-old and they don't know what's going on. They'll fight you and they're already hypoxic and having trouble breathing because they don't know what's going on. They can't understand. So having a nebulizer, even having a parent, put over their face and do blow by, that's definitely a plus for us. And when it comes to ease of administration for these patients. So if they're 5 or under, if they're less than 20 kilograms, we give them 2.5 milligrams. If they're more than 20 kilograms, we give up 5 and we nebulize. 8 liters of oxygen would be recommended for nebulizing for these patients. Ideally, when someone is having asthma, we want to put them on the monitor because, again, as we're probably all aware, salbutamol can increase heart rate, cardiac function, things like that. So we want to make sure we monitor their rhythms. Get IV access just in case, because if they're sort of stable now, let's get an IV in before they start destabilizing. Okay, it just might not be a bad idea depending on how your patient's presenting. And again, if they need it, like if you give them 2 puffs salbutamol and they're good, you don't necessarily need to start an IV. That's at your discretion. And we might want to do a 12 lead as well, because we could have cardiac asthma. We'll talk more about that with acute heart failure, but we want to see what their heart's doing as well, because just when they have MIs, that could cause fluid buildup and inflammation of the bronchioles as well. So we want to make sure that it's actually asthma and maybe not a cardiac event as well. So if we do have a patient that we give salbutamol to and it's not improving, we can always consider Cpap for asthma. So Cpap has always been used more so for congestive heart failure, but now we can look at it using it for asthma. So looking at studies, it was noticed that there was a large decrease in pulmonary resistance during Cpap use. And then when they took the CPAP off these patients, they know that the resistance greatly increased after CPAP. So CPAP will help get more air into these patients. Again, we're not forcing it like we were doing with BVMing. So we're not going to worry about the gas trapping because the patient's breathing on their own. We're just helping get more pressure into the airway to open it up more. So that way they can get more improved ventilations. So they noticed that with patients with asthma COPD, there was a decrease in inspiratory work per liter of ventilation. And so this basically just helped your patients work a lot better. And it took a lot of pressure off of the inspiratory muscles. So that made it a lot easier for your patients to breathe as well. So this can be beneficial. One thing to keep in mind, though, is that once we, just like with congestive heart failure, when we talk about CPAP, is that once we have the CPAP mask on, we have that pressurization in the chest. You really shouldn't be taking the mask off. We should be leaving that in place. If that's still not working or it's not an option, your patient can't tolerate a CPAP mask. A new addition here is consider IV magnesium if not improving. So magnesium sulfate is a beta-2 agonist resulting in bronchodilation. So it interferes with calcium influx, and this can also cause bronchial smooth muscle relaxation. It's been shown overall to be very safe as a medication to give. For patients with severe asthma that didn't respond to other first-line therapies. So with this medication, it's not our go-to. We're obviously going to try salbutamol, stuff like that first. It's very few negative side effects, and the big benefit of this one is that they found that it greatly reduced hospital admission rates when given magnesium. So with this one here, so with severe asthma, we have magnesium in here. So it's an ICP scope medication. So again, this is one of those ones where if you're giving salbutamol, it's not really working. You might want to consider calling ALS if that's available to get magnesium in your patients. So for our patients, it's 17 years and older, it's 2 grams over 15 minutes. If it's 1 year to 17 years, it's weight-based. So make sure you're checking your dosage with your partner, make sure everything is correct. A side effect, so similar to with like when we look at preeclampsia, stuff like that, when we talk about muscle weakness, is that we're always worried about respiratory, is that if they have too much magnesium on board, especially the patients with myasthenia gravis, that's still a contraindication for this, is that it could cause muscle weakness. And obviously we use our diaphragm and intercostals to breathe. So if we have weakness in those muscles, that's going to really work against us with these severely hypoxic asthmatic patients. So the thing is, though, with studies, it's shown that giving 2 grams over 15 minutes is highly unlikely to cause toxic levels where we have to worry about having that severe muscle fatigue in our patients where it's going to reduce their respirations. But again, if you're giving it and you notice that their breathing starts slowing down, they have less effective breaths, you should probably discontinue therapy. In pediatric studies, I apologize, I could not find any ones that were specific enough for adults, but it said that on average with pediatric studies that magnesium lasts an average to 2 to 3 hours. So that's pretty good for a therapeutic dose, especially when you look at long transport times with these patients. And onset is going to be variable based on your patients and depending what's causing their asthma attacks. But it could be a long-term effective. Again, definitely not your first-line dose, first-line therapy for asthma, because as you can see, you have to give it slowly over 15 minutes, and that means you could put in like a 100 cc bag and do a slow infusion. But we definitely need to deal with immediate bronchospasm. This is not going to do, like obviously salbutamol is still going to be our go-to. We're not going to go to this right away because it's going to take a while to give it. So with that's IV magnesium, and then we can look at giving steroids as well. So these are all considers. Again, would you do what you think would be best for your patient first? So with hydrocortisone, same dosing as anaphylaxis when we give hydrocortisone. So it's 5 milligrams per kilogram to a max 100, and so IV it's PCP above, and if you do have an IO because they're that bad, you can't give it through the interosseous. So the idea of hydrocortisone, it reduces mucus secretion and inhibits the inflammatory response. It may not have immediate effects. So again, same thing. It's why it's not your first line medication to go with. It's not going to do with the immediate hypersensitivity reaction, but it can prevent any further bronchial reactivity and prevent further exacerbation of the COPD, and also just like reduce that secretion factor in there. So with that, it's recommended for like magnesium and hydrocortisone that it's be used with patients with moderate to severe asthma exacerbation. If they have 2+ salbutamol and they're good, we don't need to start loading them up with all these medications if we don't think it's going to get any worse at that point. So we've considered those medications there. If we're like, okay, well, I'm a PCP, those other medications aren't an option for me. So with PCP, you can give IM epinephrine if asthma is not improving. So with epinephrine for refractory asthma, M05.3, it is a high alert medication. So make sure you double check your dosing with your partner, check your math, especially with pediatric dosing, and be a good partner. If your partner does a calculation and says this is the dose, sounds so good, you're like, sure, whatever. Like it's high alert. Both of us should be doing the math separately to make sure we get the same answer. Decimal points make a big difference. So we're going to use the epinephrine for refractory asthma if basically nothing else has worked. So we're giving them all the meds. Again, we have to understand that magnesium and hydrocortisone may take time to take effect, and we've kind of run out of options. They can't tolerate Cpap. The other meds aren't working yet, but their chest is completely quiet. They're hypoxic, and we tried everything else. We can start looking at giving epinephrine. So contraindications for this is if it's a COPD exacerbation, epinephrine is not really going to have the proper response that we're looking for to help with these patients. If you've had undifferentiated respiratory failure, so you're really not sure what's going on, we don't just want to jam epi in them, just as let's give it a shot and see if it works. We should have some kind of diagnosis working for that. Wheezing due to heart failure. So with cardiac asthma, it could be coughing or wheezing that occurs with left-sided heart failure. This wheezing is caused by fluid buildup in the lungs around the airways. So when it giving epi isn't going to fix this. And if they're having an MI, epi can actually be very detrimental to your patient. So we want to make sure that it's not cardiac asthma versus just bronchospasm from some kind of irritant. And obviously, like I said there, so chest pain suspicious with MI, we're not going to just jam epi into these patients. So if we're really concerned about maybe cardiac involvement, we should be dealing with that first before we put epi in them. If you're not sure, you can always call Online Medical for direction on this. So to give medications for this is a little bit different than the anaphylaxis dose. So for 6 years and up, we're going to give 0.3 milligrams, and for 12 months up to 6 years, we're going to give 0.15 milligrams. To administer this, though, it's going to be the same. We're going to inject it into the vastus lateralis, same as anaphylaxis, just for increased absorption because of larger muscle. If you do have less than one, like this is their first ever asthma attack, it's really severe. Again, just going back to delegations and standing orders. If they are under one, we don't have a standing order for that. You need to call Online Medical to get the dosing. And that's asthma COPD. I mentioned a few times already, so the next thing we're going to go is acute heart failure, E08. This is a new care map standalone on its own. So patients with acute dyspnea, worsening of chronic dyspnea, respiratory stress, respiratory failure, suspect to be due to heart failure, we're going to access this care map. So when we talk about acute heart failure versus ADHF, so acute decompensated heart failure, it may be due to a variety of cardiac diseases. It may occur suddenly due to a new cardiac event, or a patient may more gradually have issues with fluid retention due to a failing heart. Again, it's commonly called congestive heart failure, but it may not always have a lot of fluid in the lungs. You may just get bronchospasm because there's a difference between chronic heart failure versus pulmonary edema, which refers to fluid overload in the lungs causing respiratory stress. You may see jugular venous distension, lots of crackles in the lungs as well, and it's specifically cardiogenic pulmonary edema. And again, wheezing might be present with this. So there's a little bit of terminology there. And obviously contraindications for this care map is it's not applicable because if we're not concerned that it is acute heart failure, we're not going to access this care map. So first things first, again, always ensure good airway, make sure they're ventilating first. Before we start ramming meds into people, we should make sure they're breathing. That's kind of a big deal. So we want to make sure we support the ventilation is appropriate, give them supplemental too. So with these patients, respiratory failure may be present with a pulse oximetry measurement less than 90 or a higher end tidal of greater than 45. A big thing to keep in mind is that these patients may be agitated or irritable or non-compliant. So we're going to assume that's going to be due to hypoxia or increasing hypercapnia. So again, if they're more acidotic to get them less, they might be more reasonable with this or combative. So with this, if they are combative, we're not going to access E02AB, the agitation care map, because we have to understand that this is due to hypoxia. It's not like they have anything else on board. It's not a psychiatric issue. If we start giving them a DAS to sedate them so they're more compliant, we can make them go in respiratory stress or failure. So we have to keep in mind that these patients may be combative, but it's usually due to hypoxia. So we want to put them on the monitor and see what's going on, especially if we're worried about the heart. Get IV access sooner than later, especially if they're getting sicker. The sooner we get an IV in, the better, because we don't wait them for the crash. It's going to be hard to get an IV once they've crashed. And get an ECG. Like, is it an MI? Is it cardiac? Then we can start talking to cardiac, the cardiologist, look at bypass. The other thing as well, so when we do a 12 lead, our therapy for acute heart failure is going to be nitrates. So with that, if we're worried about ACS, we want to see if they're having right-sided infarct as well, because that would be a contraindication nitroglycerin therapy, which is one of our main go-tos in this care map here. So again, based on how stable they are, obviously if the patient's struggling to breathe and they've got pink frothy sputum coming out of their mouth, we might not be able to take the time to do a 12 lead. But if they're handling it not too bad, we should really be checking their heart. So if you do a 12 lead and STEMI is identified, we're going to go down to our STEMI care map for ACS. We're going to contact the cardiologist based on our findings. We can consider Cpap for these patients. So Cpap has been shown very beneficial for these patients. I'm really glad when we got it back. It is a great tool to have in the field. It basically has a positive airway pressure on aerodynamics, on hemodynamics inside the lungs. So it decreases systemic venous return because it has that increase in intrathoracic pressure. So it reduces the blood flow return to the heart so it doesn't overwhelm it. But that also helps, that increase in intrathoracic pressure, because the heart has to pump harder to push blood out. It increases right ventricular preload. So that's beneficial for our patient because by increasing that right ventricular preload with less, like it doesn't have as much fluid going back to the heart, so you don't get as congested. It helps increase the lung capacity, but it also reduces right ventricular afterload. So that can be, it can be increased by Cpap. So with that decrease in right ventricular preload, it can cause an increased right ventricular afterload. So that causes reduction in pulmonary venous return and limitation of left ventricular inflow. So basically that increase in thoracic pressure reduces the amount of venous return to the heart, but means that you get better contraction from the right side to go to the lungs, and it can get more effective because it increases the intrathoracic pressure inside, so you get better gas exchange. And then when you get it back, it doesn't put as much fluid into the left ventricular, so that reduces that, so it's less force on the heart. So basically, it just works on your whole circulatory system. I hope that all made sense. But it stops the fluid overload, and it helps whatever blood is going through to get oxygenated more effectively and just less fluid in the lungs. And it'll help better contractions and perfusion for your patient. It's actually been shown to increase blood pressure overall in our patients as well. So we can look at giving a nitro patch. Obviously, if we have Cpap on, it's working, but we want to give nitro, we're not going to take the mask off to spray. Don't do that. Once you got that ceiling, you got that pressure gradient inside the chest, that's awesome. We don't want to deal with that. We don't want to mess it around with it. So we're going to give a nitro patch. So we have options with that. So when it comes to giving nitro, so indications, just as per the nitroglycerin medication profile. So chest pain or discomfort consistent with MI or pulmonary edema, which is what we're going to have with these patients here. So contraindications, these still ring true here. So if their patient's hypotensive, we're not going to give that. If we have a known right ventricular infarct, again, known, if we got a 12 lead on board and we know that they're having a possibly right MI, then we're not going to give it. If we didn't have time to do a 12 lead because they're severely sick, we can, hopefully get an IV first, and then we can try it. But again, ideally try to do a 12 lead. If they've used any of the following last 24 hours, any ED medications in the last 24 hours, increase intracranial pressure, and obviously if they're hypersensitive to it, if they have bad reactions, we're not going to give it. So for our scopes here, so for sublingual nitro spray, older than 17, we just give 0.4 underneath the tongue, 5 minutes is required. As you notice, there is no repeat dose, but we should be checking blood pressures in between, because obviously if they have a large drop of like 30 milligrams or more systolically, we don't want to give more. We don't want to bottle them right out. If we're going to give it transdermal, so we could do 0.4 to 0.8 milligrams per hour. So depending on how your patches are delivered to you, you need to, if you're getting 0.2 patches, 0.4 patches, you need to know that ahead of time. But we can put patches on. Again, if we have Cpap on, don't break the seal to give sprays of nitro, maintain that pressure that we've developed inside the lungs. So just put a patch. And ideally, when we put a patch, you want to put it, as per the manufacturer, on the anterior part of the chest, underneath, around the clavicle, underneath the clavicle, on the chest. That way it's easier for us to notice it. And if they become hypotensive, it's easy access for us to take it off. A big thing to keep in mind with acute heart failure, especially when we put them on the monitor, is look at their rate. Because if your patient's severely bradycardic, nitro may not be a good idea, because if they're really, really high rates or really, really low heart rates, that could be causing the fluid buildup. Because if your heart's not perfusing properly because they're having an MI and their heart rate's at 20, they're just having fluid backup because of poor perfusing heart. So when it comes to differences in rates, we don't want to give nitro for that, especially if they're bradycardic, because we have to deal with the rate first. And hopefully, if we get the heart beating at a normal pace, that will help circulate the blood more effectively, and that might solve our problems with the fluid in the lungs. So don't just go give nitrates if they have severe highs and lows in heart rate. So we can look at giving nitrates, and as an ICP, if that's not working for us, we can also start furosemide. So with that, it's diuretic therapy that can be effective in relieving symptoms if given early. So the thing is, to get full effect of furosemide, it may take a couple of hours. So if you have a nitro spray, your patient's still getting congestive heart failure, all that good stuff, we can look at giving Lasix for that. Yeah, the onset of furosemide can be within 15 to 20 minutes, but if anybody's ever given this field, the big thing is have a urinal ready because this makes you pee. So just a heads up there if you've got a long transport. So to give furosemide, so indications are heart failure with evidence of pulmonary edema. We're not going to give it to they're allergic to it, if they're already hypotensive, or if they're dehydrated. So furosemide inhibits electrolyte reabsorption in the kidneys, forcing excretion of water from the body, and this basically just takes fluid out of the system to help relieve the fluid buildup in the lungs. If your patient's already severely dehydrated, this could cause worsening of their state because it's going to cause more electrolyte imbalances. So they're going to be peeing out a lot of sodium, potassium, things like that. So if their heart's already having trouble beating, there's a lot of electrolyte imbalances to start with. Plus they're dehydrated, we're going to make them more dehydrated. So it may not be beneficial to your patient to give them this. So when it comes to giving furosemide, if they're currently taking it, it's 40 to 80 milligrams. So you could look at what they're taking as a regular dose. So obviously if their regular dose is 80 milligrams, 40 may not cut it. If they're not taking it at all, so we could give 20 to 40. So based on what you're seeing with your patient. The one thing to keep in mind is patients with known renal failure, they should receive the maximum dose. So if they're already taking it and they're a dialysis patient, we should give 80 milligrams. If that's still not helping, again, because Lasix is not going to be insta-fix, it's going to take time, like I said, maybe 20 minutes before you even notice any change. And, you've got a very sick patient. You can try salbutamol. Again, it's not really going to be your first go-to. You want to rule out all the cardiac stuff first, but we could try salbutamol down the road. Because salbutamol is a specific beta-2 adrenergic agonist. So the benefits with that is it relaxes smooth muscle and reduces systemic vascular resistance. And it has a positive inotropic, so the speed of contraction of the cardiac muscles, as we've all taught, it speeds up your heart rate. It can possibly cause an increase in blood pressure and a fall in pulmonary and diastolic pressure. So that means that you're getting more blood perfused. It's reducing that amount left in the lungs afterwards. You're getting the blood going. You've opened up the airways, so you got better gas exchange, change in pressures, things like that. So you could give that a try. But again, if it's probably cardiac asthma, this may not have the effect you're looking for. But again, there's a reason it's the last one on the list there. We can try that as an option. And that's acute heart failure. E08. So we have respiratory stress of an unknown cause. This is kind of like, okay, well, it's not asthma, it's not COPD, it's not anaphylaxis, it's not congestive heart failure, what's left? And that's basically where this care map falls in. So we activate E09, respiratory stress of an unknown cause, for patients with acute dyspnea, worsening chronic dyspnea, respiratory stress, respiratory failure of an unknown cause. So basically, it's like this patient's having trouble breathing. What is going on? So contraindications, so obviously if there's care maps to cover what's going on with them already, we're going to go to those, like obstructed airway, they've got asthma, COPD, anaphylaxis. We're just going to refer those care maps. So not really reinventing the wheel too much with this care map here. So obviously airway, make sure they're secured. If we need to assist ventilations, we can get IGL and OPA and give them O2. Other things we look at is if we're thinking it's going to be beneficial, we can try around CPAP, get IV access, put on the monitor, see what's going on with their heart. Do a 12 lead. If they're having a STEMI, we're going to go to STEMI bypass, and we're going to go that route. And we could try salbutamol or consider a trial of salbutamol. And that's pretty much in transport. So again, this one here is just kind of give you a guideline of, okay, I'm not really sure what's going on. Do your thorough assessment. Okay, well, maybe this is a good option. Maybe this is not. But again, we've got lots of care maps to cover the vast majority of our respiratory distress. This one just kind of fills the gaps. So the new one as well is pediatric febrile seizures. So this one was removed from E14. So this used to be part of the seizure care map, and it has been taken out and created into its own care map. So pediatric febrile seizure. So obviously we're going to use this care map if we have pediatric patient that's having febrile seizures. But if they are having active seizures, we're going to treat as per E14, which is your seizure care map. So benign febrile seizures, usually brief, cell limited, and do not always require medications. So like honestly, most of the time, by the time we get there, their seizure is done. And febrile seizures are usually rare after childhood. If you have an adult that's having febrile seizures, that is a huge concern because that means they have a severe viral bacterial infection, and yeah, they need to go to the hospital ASAP. That is a bad, ominous sign in these patients. So when it comes to pediatric febrile seizures, for pediatric patients, if they are actively seizing when we get there, obviously we need to stop the seizure before we start looking at any therapy. So we're just going to follow the seizure care map here. Again, keeping in mind pediatrics, it is all weight-based. So be a good partner, check your math with each other, decimal points count. There's a huge difference between 0.2 milligrams and 2 milligrams. Or even 0.02 milligrams, right? So we want to make sure we're doing our math appropriately. And again, big thing to note is in our standing orders here for all for pediatric patients, they all start at 12 months and up. So if you have an 8-month-old that is having febrile seizures, that is actively seizing, you'll have to contact online medical to get appropriate dosing because we don't have a standing order for less than 12. If you know you're going to a 7-month-old, you have like 20 minutes before you get on scene. If you're going to like a 7-month-old that is having active febrile seizures, it wouldn't be wrong to call ahead and say, hey, we're going to this pediatric seizure patient. They're less than 12 months. We don't have a standing medication order for that. If they are seizing, what's the dose per kilogram that I should give this patient? And you can do that before you actually get on scene, just so you're ahead of the game. So when you arrive up on scene, if the baby's still seizing, you can start dealing with that right away instead of making a phone call when you're on scene. Okay, so just something to keep in mind there. So if they're not actively seizing, we want to manage and support ventilation is required. Again, if they're actively seizing, we're going to go in and we are going to deal with that. So when it comes to this, though, respiratory depression, hypoxemia, and airway compromise are usually uncommon after the seizure ended, but we always want to make sure pediatric patients have proper airway. So again, make sure in that proper positioning and be ready for suctioning because again, if they have a lot of secretions, they have smaller airways. They can't deal with a lot of secretion. So, just simple BLS stuff, roll them on their side. You can use suction, but if you are going to use wall-mounted suction, especially with little ones, is that we have to be careful not to use too much suction because we can actually cause trauma to the airway, which can cause secondary swelling, which really isn't going to help our situation here. So if you are going to suction, use a lower setting. And a big thing to keep in mind, again, so just doing that blanket roll, we have to remember to do this, that after the seizures are ended, if we want to make sure their airway's open, we want to make sure we're in that proper head positioning, especially for little ones. So we want to put that blanket towel roll underneath the shoulders. So one big thing to keep in mind that I teach this a lot is if we're using an eye gel sits at the opening of the trachea. So the problem is when kids have their heads, when they go forward, when they lay flat, is it kinks off the trachea. An eye gel is not going to protect that. So if you have a patient that's postictal, you're having to assist respirations, make sure you still have that towel roll underneath their head, even if you have an eye gel in place, just to improve your ventilations. So that can still help with the airway. So as soon as the patient is able to tolerate oral medication, you can give acetaminophen or ibuprofen. So again, if your patient's got a GCS of 3 the entire time, don't start ramming Tylenol in their mouth. It's just going to cause a choking hazard. So this is if the patient can tolerate it and they're with it enough to actually take it. So with that, we have M0 2.1. So we have acetaminophen or Tylenol. So acetaminophen reduces fever by acting on the hypothalamus of the brain itself, and that's what's responsible for regulating your temperature. So that's what Tylenol does for these patients. So we can give, again, indications, pain and fever. So obviously we're going to go with the fever side of things here. We don't give it if they're allergic to it. And again, just with pediatrics, if they've never had it before, we don't know if they're allergic to it. So just highly unlikely, but it's always possible. So just make sure you're aware that you keep an eye out for any kind of allergic reaction to it. If they have known or suspected liver failure, so Tylenol does have hepatotoxic properties, which can cause injury or impairment of liver function. So again, if we know they've got any kind of liver issues, again, when we're talking about pediatrics, probably not a huge deal, but we can just ask the parents if they have any liver problems before we give it. And obviously, we're not going to give any more medications if they think that they're going to need surgery or anesthesia in the next 4 hours, because obviously we're worried about vomiting and aspiration. So dose for Tylenol, 12 years and up, 650 to 1,000. For a pediatric, it's 10 to 15 milligrams per kilogram to max is 650. If, again, under 12 months, we don't have a standing order for that. So if you're looking at giving it to a 6-month-old, we should make a phone call to confirm. Don't go by what it says on the bottles for these patients. I know it's an over-the-counter med. It has the dosing on the bottle. But the thing is, we have standing orders. We need to follow our standing orders, not what the bottle says, because they don't always match up. Pharmacy, depending on where you are, has different sources, different places to get their meds from, different concentrations. So we should really be following our standing orders, not what it says on the side of the bottle, because sometimes they don't match up. Sometimes they do, sometimes they don't, but we don't know that for sure. So follow your standing orders, don't follow the directions on the bottle. And the fact we don't have standing orders for less than 1 year, if we have a patient in 6 months, we need to get some direction on that. So the other medication we have here is ibuprofen. So it's an NSAID. It works on the body's chemical pathways for pain. It also reduces your body's ability to make prostaglandins, which are the natural chemicals that trigger pain, inflammation, and fever. So basically, the idea is with reduced prostaglandins in your body, pain, inflammation reduced, and your fever goes down as well. So that's what we're kind of going for with this medication as well. A big question I get asked is, when do you give Tylenol? When do you give ibuprofen? It's kind of your discretion if they've not had either one yet. Obviously, if the parents are loading up the kid with Tylenol and it's not working, then we could look at giving ibuprofen, or if they're giving ibuprofen, we can give Tylenol, things like that. It's going to be very situational. It'll be at your discretion what your preferences are. So with this, again, we're going for fever. Again, if they're allergic to it, or they could have ASA-induced asthma, it's just a side effect caused by the medication. It can cause bronchospasm. So we're going to stay away from giving that. If major trauma or active bleeding, we don't want to give ibuprofen again. So these are all reasons why we do and don't give these medications, with contraindications as well. Any active bleeding, so that could be GI bleeding, stuff like that, because ibuprofen decreases platelet aggregation, reducing clotting time and formation of clots. And it can take up to 24 hours for this clotting factors to normalize. So if we're worried about any kind of trauma, we're not going to give it. If they're pregnant, so obviously with our pediatric febrile seizures, we're not going to be worried about pregnancy. But just because it's in there, ibuprofen has been known to cause birth defects with very low numbers, 3 to 5%. But after 20 weeks, it has reports of NSAIDs affecting kidney development in the fetus, as well as premature closure of the ductus arteriosus, which can cause an increase in fetal blood pressure in the lungs. So obviously that's not going to be good for a baby. It also may slow down or stop labor. So again, we're dealing with pediatric febrile seizures, so I'm pretty much guaranteed that's not going to be an issue, but good to know. So for end-stage renal failure, so again, kids can have poorly functioning kidneys. That could just be a birth defect. So we need to ask about that if they have any kidney issues, because it can cause several different forms of kidney injury, including hemodynamically mediated acute kidney injury. It can cause electrolyte and acid-base disorders. They could have nephrotic syndrome, which causes a lot of proteinuria. So just basically they're peeing out a lot of protein. It can actually cause damage to the papillary, can cause papillary necrosis. So basically that's death of the renal papillae, which are the areas where the openings of the collecting ducts enter the kidney when urine flows into the ureter. So kind of a big deal. So if we're worried about their kidneys in any shape or form, we shouldn't be giving this. It's got a long history of causing, and even with circulation to the kidneys, that can cause problems. And again, just like Tylenol, if you think they're going to need surgery or anything, we don't want to give them any oral medications because aspiration concerns. So for ibuprofen, we have our initial dose 12 and up, 400, 800 milligrams, and for 3 months to 12 years, 10 milligrams per kilogram. So again, with Tylenol, it starts at 1. Ibuprofen starts at 3 months. So with that, you could look, it's basically they have different age ranges, right? So with that, Tylenol can be given to younger kids versus ibuprofen, you start at 3. So with that, it could be based on the age of the child as well. So we want to make sure we're giving as per their age. So if you have a patient less than 3 months and you think ibuprofen is beneficial, we need to call online medical because we don't have a standing order for that. And that's pediatric febrile seizure. So obviously we're going to transport to the appropriate facility. A big thing as well, just to throw it out there, is that it talks about giving medications, but also like if you give midazolam to stop a seizure and they may be sedated, you may not be able to give Tylenol, ibuprofen, because obviously if their airway's compromised, or even if you're ventilating with an eye gel, but we still want to cool these babies down. So with that, during transport, we can do passive cooling. So just remove all the clothing, like don't crank the AC, don't get too hardcore with it. Just allow that heat to leave the body. Because and especially don't start covering them in ice packs. They used, like way back in the day, they used to do ice bash these babies. It doesn't work because aggressively cooling an infant can actually induce seizures as well. So we're not doing this kid any favors. We're making them going from too hot to too cold. Their little bodies can't handle it. They may not be old enough to even start shivering yet. So we got to be very careful with that. So don't aggressively cool these kids. Just passively cool them. Just allow the heat to escape. Don't bundle them all up in blankets and stuff. So that might just be down to the diaper on your neomate, and just allow them to get rid of that heat to the air, so that way we don't have a febrile seizure. And like I said, transport appropriate facility. So thank you very much. Those are the updates on the care map updates that are going to be placed on the Shared Health website as of October 10th. Thank you very much.